Hello, and welcome to the webinar. My name is Victoria Rashke, Director of Technical Assistance and Training for the Council, and I'll be acting as moderator for today's webinar entitled Introduction to the Community Health Workers Guide for Administrators, a production of the National Healthcare for the Homeless Council with support from the HRSA Office of Special Population Health. I would like to remind you that this session is being recorded. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. A selected number of questions will be answered at the end of the presentation during the Q&A session. Now I'll hand it over to Katy Valesky, our host and first presenter, for introductions. Katy.
Thank you, Victoria. Lamont Witherspoon is a community health outreach worker at the Baltimore HCH project, and he'll be speaking later about his experience doing this work. You can see my photograph there. I'm the consumer advocate here at the National Healthcare for the Homeless Council, and I will be speaking with you about my research on community health worker and their method application in HCH. First, I want to do an overview of community health workers. In general, community health workers are employed to help communities reduce health disparities through health education, outreach, enrollment, navigation, community advocacy, and translation services. This method of engaging community members to reduce health disparities dates back to the 17th century in Russia. China has also used what they call barefoot doctors to treat rural citizens without access to a formally trained doctor. There are other examples in developing nations all over the world. The first documented use of community health workers in the United States occurred in the 1970s, and their methods were modeled after Mexican promotores de salud, or promoters of health. In the United States, community health workers come from a broad range of backgrounds, but they have some common characteristics. One is that they either came from the community that they serve or have a very close knowledge of that community. Community health workers also have a passion for serving and empowering those who would otherwise lack access to health information and resources. They're able to empathize with their clients because of their similar experiences, and this drives their passion to help. Community health workers may have varying education levels, but report their experiences with the healthcare system are what inform their work the most. This can mean anything from managing their own diabetes to knowing what it feels like to live on a bench on the corner of East and Main. Another salient characteristic of community health workers is their ability to work both with their clients where they are, but also with professional healthcare providers where they are. This agility is critical to connecting the community with the healthcare providers in a respectful and culturally competent way. Community health workers are expanding their reach in the United States healthcare system because deep health disparities still exist, unfortunately. The Center for Medicaid and Medicare Services recently found that community health work intervention resulted in significantly increased use of health screenings among minority patients diagnosed with diabetes. The Health Resources Services Administration has published 3 large studies establishing that community health work has the potential to increase access to care, improve health status, and reduce the cost of care with a community-centered approach. And as you can imagine, CMS and HRSA are both very interested in increasing quality and reducing cost. On that note, several studies have actually been published verifying that community health work has the potential to return on investment in large ways. One study in Denver found that every dollar invested in community health work returned $2.28. Each community health worker in Denver saved more than $95,000 per year, and this was while the patients reported an improved quality of life. Another study in Hawaii successfully reduced overall health spending for participants by 75%. Also, improved quality of life was reported. In Austin, one hospital reports that they were able to significantly lower emergency room visits while primary care visits increased, and this hospital saves $300,000 per year as a result of their investment in community health workers. This is just one hospital's savings. With health reform and the Affordable Care Act, many more opportunities are opening up for increased use of community health workers. The Affordable Care Act authorizes the Centers for Disease Control and Prevention to fund community health work, especially as it relates to education and outreach, promoting positive health behaviors, enrollment in public health insurance programs, enrollment into health care agencies or health homes, and home visits for maternal and prenatal care. All of the above apply in the HCH setting, although it is understandable that HCH projects will be most interested in one or the other of these depending on the circumstances in their community. Enrollment activities will be especially important as Medicaid expands to include eligibility criteria that will apply to almost all consumers of HCH projects nationwide by 2014, possibly earlier in other states. Given these guidelines, there are three primary roles identified for community health workers in an HCH setting. The first is outreach and enrollment. This includes assisting consumers with enrollment into insurance, the community health center, housing, nutrition, and other programs based on the needs identified by the client. Outreach is an essential part of enrollment as it establishes a trusting relationship through which the needs can be expressed by the client. The second primary role for community health workers in the HCH setting is logistical support, also known as navigation. As many of you know, the healthcare system is very complicated and difficult to maneuver around, even under the best of circumstances. Community health workers help patients navigate through the system efficiently by helping remove barriers to care. This may include helping consumers fill out forms, encouraging follow-up care with primary care physician or specialist, follow-up and tracking, transportation and accompaniment, and or translation services. There's a lot of overlap between this role and the ideas included in HRSA's definition of enabling services, which are basically services provided to allow for ease of access to community health resources. The community advocate educator role is more about the community's response to homelessness. Work in this role might include getting community resources around the table to develop a plan for evacuating those who are homeless in the event of an emergency, or educating local law enforcement on what they can do to help those experiencing homelessness in the community. This role involves a lot of listening to the community and giving information to the health provider team about what issues consumers are facing. Armed with this information, the provider team and other community partners are able to address community concerns. I'd now like to introduce you to Lamont Witherspoon. He does a lot of the work that I've described, and he has a great story. He's been doing community health outreach for 12 years. He's worked at both Johns Hopkins and the Baltimore HCH Clinic, and is currently a member of the community health outreach team at Baltimore HCH. He specializes in helping those with mental health and substance abuse disorders, and says his ability to overcome his own personal barriers are what inform his work the most. Now Lamont will share more about what he does, how he does it, and how it benefits Baltimore's HCH. Lamont?
Hi, my name is Lamont Witherspoon. I'm here in Baltimore, Maryland. I work for healthcare for the homeless. I'd like to tell you a little bit about myself. What fascinated me about outreach is a little personal story. Had broke my neck and I was in a psychiatric unit, going through the drug rehabilitation, and I had this guy come over to me, try to talk with me, and I would always try to push him away and say things just to make him mad. Until one day he said, "You're not mad at me, you're mad at yourself." And I was kind of wondering, what you mean? And he did an ASI one. It talks about things in your background, when you was a kid, your parents, and it helped me realize a lot of barriers in my life, and it gave me the opportunity to break a lot of abuse cycles that went on in my earlier life that led up to my drug use. But enough about that. I wish I had a cue card. I probably could have put it together a little better. But here it is. As far as doing outreach, I love getting out there, meeting people, because if I felt as though someone may be lost like I was at first and just needed someone to reach out for them, to be there, to try to keep a little bit of dignity that they had, and just tell them where they can get stuff at, but share a little bit about their background so you won't just think it's all textbook. And with that, I found out you build a very good relationship with people. And as you build a relationship, you you continue that by motivating them, like listening to them, try to help them develop a long-term goal, but take the short-term process getting there. You know, like most people, we may think they need mental health or addiction or medical treatment, but that may not be where the client is at. So I try to keep them motivated and interested and share some of my personal background with them. They like to know. You know, try to get them enrolled in services. Now, that's the key. Every time a client is not going to be right there where they should be at. So the challenge is meet them at the level of their needs. Like, not tell them this is what I think you should do, but make sure they know what's available to them, and then be available when they're ready. And only remember that you're just a guide for them, because we can't really do the work for them. Some of the things I learned that you don't do, don't tell the clients what they should do. Don't be too passive with them, because most of the time our clients out there panhandling or just surviving, and the last thing they need is somebody to say, oh, poor you. That may not be where they at. You know, they may need for you just to say a kind word so that they get used to someone recognizing that they're alive. So I try not to push too hard or take credit for their improvement if a client all of a sudden say good morning back, you know. So that's one of the challenges I do like. But the things that led me up to that point was a lot of helpful trainings that I took, like motivation interviewing, I have mental health counseling. You know, I have this boss that she's very wonderful, Mary Stewart. She just won an award last month up in D.C., and I was blessed with the opportunity to go up there with her and share that experience with her. She gives me a free hand in my work, along with my peers here at ACH. You know, a lot of people, they understand the passion that I have for my work, and Lord, just to be part of a team, to see everybody come together to get one common goal to help an individual get some help. I had this guy, I had to call him yesterday to ask his permission to use his name. He's out to tell a story, but he said, no, you can use my name. He said, because it took me 3.5 years to make a connection with him. He went from Pitt, he used to live underneath of the bridge, but his first need was like, wow, if we could get him housed, and maybe we could overcome some of the other barriers, you know, from him being in foster care, going here and there, not taking medicine. But just a few weeks ago, this client walked up to me, had gained a few pounds, and he said, Lamont, he said, you can call me Frederick. You don't have to call me Pitt no more. He said, you know what, I finally been taking my medicine. And he said, you know, when you transition me on in the process, he said, you turned me on to some good people here in the agency, and I started opening up. He said, I never thought I would take that medicine. He said, because I wasn't crazy. I just did some crazy things. And, you know, we just sit down and laugh about it. But he shows up at this church I go to and do outreach every Friday. And he comes there to give back to the community as well. And he's a big inspiration to a lot of other people out there, whether you know it or not. He thinks I'm his inspiration, but I'll tell him, you're doing the work. I'm not doing nothing that you or anyone else could do. So, you know, once again, like I said, I never try to take any credit, but it's always credible when you see someone blossom from a thorn into a beautiful rose. Now I'll pass it back to Victoria.
Thank you, Lamont. I'll begin the Q&A session now. Our first question is from Liz Brookshire, and she asks, how are CHCs identified and compensated? And Katy will answer this one for you, Liz.
One thing that I found in all of my reading and research was that community health work in the HCH setting, or even with homeless individuals, is a relatively new field. But I have met with other community health workers in other fields, and they typically identify what they call natural healers, those people in the community who kind of serve as traffic cops to tell folks where they should go and what they should do. And that's the most successful way of identifying community health workers I read in the research. And it does make a lot of sense. Compensation is always tricky. there isn't a great source of funding except for there are enabling service grants and all those type of things through HRSA. However, most of them are funded through short-term grants right now, so they're not very stable positions. I do know that our colleagues at HRSA and CMS are very interested in investing in this work, so I hope that that continues into the future.
Thank you, Katie. Our second question is kind of similarly about qualifications and identification. Question is, what is the minimum educational requirement for a community health worker? And Katie, I guess this one will be for you as well. Each agency around the country who works with community health workers kind of sets that. Many don't require any formal education. The education that's required is that's learned in the community, who to talk, what the different resources in the community are, where to go if you need food, where to go if you need shelter, where to go if you need a public bathroom. That type of knowledge is what's more important. There are some places that require a high school diploma. Very few of them require any post-high school education, although some is offered. I have a question for Lamont. Lamont, the question is, have you had an opportunity to interact with any other community health workers in your work, and what has your experience been like with other community health workers in the field?
Yes, every Monday I go to this HIP meeting where it's like 15 to 20 different other outreach workers throughout the city of Baltimore, and we sit down and we discuss vulnerability of clients. And sometimes one agency may pass to another agency or interact just to assess the client's need and get them the help. At the same time, at this meeting, we also have a limited amount of housing vouchers where sometimes the client's immediate need may be housing, and then we can get them medical or mental health. But through this HIP meeting, we're able to do that. We have a lot of resources, and we also invite other agencies in to bring resources to the meeting.
Thank you, Lamont. Yes, Lamont, did you train to be a community health worker using any standardized curriculum? And in Baltimore, do they monitor outcomes based on your work?
Yes, I did. Actually, I received training from Johns Hopkins, as well as various training that I have to go under through my grant, which is the PATH grant. For mental health, there's a lot of housing resources, substance abuse, HIV counseling and training, client de-escalation, CPR. I mean, it's just numerous of trainings that we go to because, like I say, in order to meet the challenge of the needs of the clients out that we run into, we have to be equipped with a lot of knowledge too, because a lot of times what we as individuals refer to another client could be a life or death sentence to them.
Thank you, Lamont. And Katie has some more to add about kind of the curriculum for training community health workers in general and how that's monitored.
The most robust curriculum that I've been able to get my hands on that's publicly available was actually published from San Francisco. They've been doing this work almost for 40 years and actually have some post-secondary educational credits you can earn from the City College of San Francisco on community health work. They published a textbook that I've used a lot. However, they don't mention those who are homeless except on maybe 3 pages out of 1,000. So it's interesting. And then monitoring outcomes. The community health workers that I've read have really looked at health outcomes as a result of their intervention. So looking at the year prior and then the year subsequent. So they look at hospital admissions, emergency room visits, all the way to A1C and different medical, I guess, evaluations such as that. Blood pressure, they'll see blood pressure go down, that kind of thing.
Thank you, Katie. Has anyone considered working with hospitals with community health workers to reduce avoidable admissions? This especially might be an opportunity for funding since discharge planners are short-staffed and more focused on Medicare.
I think that's a great idea. I think there's definitely a partnership opportunity there. Many of the community health workers I studied, especially the ones in Denver and Austin, they actually have community health workers sitting in the emergency room, helping figure out, do they really need to be there, or do they need to follow up with a primary care doctor the next morning, and following them so that they don't return. Some emergency rooms are seeing patients 10, 12, 15 times a month, so they're focusing on those individuals to see if they can get them into primary care so that that isn't necessary.
Great. Thank you, Katie. And I believe that that is our last question. Several people asked what the name of the textbooks is that they use there. We can send that out with the information for the webinar. Or if you would like to contact Katie, her information is also in the last slide. Thank you for joining the Introduction to the Community Health Workers Guide for Administrators webinar, produced by the National Healthcare for the Homeless Council. This webinar will be archived on our website at www.nhchc.org within 72 hours. Questions which presenters were unable to respond to will be addressed via email if possible. At the close of this webinar, you will receive a survey to evaluate today's presentation. Please complete it so we are able to improve your webinar experience. A link to the archived webinar will be emailed once it is posted to our website for all of those who registered. Please join us for our upcoming webinars on the NCQA process for recognition as a patient-centered medical home, motivational interviewing, and the third one on achieving Level 3 patient-centered medical home recognition. Registration for these upcoming webinars is available at www.nhchc.org in the webinar section. Please also check back for registration information for our upcoming regional training in Detroit, Michigan on September 19th and 20th, featuring sessions on healthcare reform, trauma-informed care, and clinical topics related to healthcare for persons experiencing homelessness. This meeting will now be closed.